Why do you feel that we are failing TB control? Because we are seeing more and more TB coming up in the recent years, and we are seeing more and more drug-resistant TB coming up. How many of you all have seen drug-resistant TB? I think more you will search for it, more you'll pick up. At Wadia Hospital, we have a TB clinic, okay? And I started this clinic in the year 2007. It's 2016 now, so 9 years. We've crossed almost 2,700 patients till now. So you can imagine the amount of epidemic of TB that we have. In the early 1990s and 2000, the epidemic in India was HIV. Now HIV is coming down with a lot of advances in treatment and nationwide public health program and diagnosis of early treatment and PPTCT, HIV epidemic has fallen. Now the recent epidemic that we are seeing is TB. So we have a partnership with the municipality where we give these medicines free of cost to all patients who require first line. The other day I was sitting in the clinic and that fellow came and told me, Madam, we didn't get any prescription today for first line AKT. So I told him today I had 10 new patients and all these 10 were drug resistant TB. So I could not give you first line. Okay, so that's the changing scenario that's happening. We are seeing a lot of drug resistant TB now, especially in Mumbai. Probably we are a tertiary referral center, so we get a little selection bias. But that's the problem that we are seeing. And yes, we are failing in the control of TB completely. Now why this is occurring? Is it because we are not diagnosing them? If we are diagnosing them, are we not treating them properly? Is the compliance a problem? 6 months therapy? Are these children missing out on the drugs? So what's the issue? TB, say around 5 years back or 6 years back, no new drugs for TB, no new tests for TB, we don't have anything new for TB. Now we've got a lot of advances in TB, we've got a lot of newer methods to diagnose TB, we've got gene expert coming up, we've had molecular tests, nucleic acid acidification tests that have come up. We've got advances in culture, so instead of your LJ medium which takes 6 weeks, we have these liquid culture mediums. You have a TB MJIT culture medium which gives you a turnaround time of 3 weeks. So you have advances in diagnostics, you have advances in treatment, you've got new drugs now. So you've got bedaquiline, delaminid, these are exclusively drugs identified for TB, currently not available as a prescription based. You need to have it only in the program because it's used for XDR TB, extremely drug resistant TB. You've got newer regimens, what we give HRZE as intensive phase, followed by HRE as your continuation phase. There are a lot of trials now going on where they are trying quinolones for first line in combination with other drugs, and they are trying to shorten the duration of therapy. These trials are ongoing. So probably in a few years we'll have newer regimens for treatment. So compliance is definitely an issue when you talk about 6 months therapy. See, when these guidelines were formulated for 6 months, 80% of your patients will get a cure by 3 months therapy. Around 90% will get cured by 6 months. And around 100% will get cured by 9 to 12 months. When they analyzed the data, they found that if they're giving 9 to 12 months, compliance really goes down. When they're giving 3 months, compliance is the highest, but the cure rate is less. So the 6 months came up because you have a 90% cure rate, plus you have a good compliance. So that's the reason you have a 6 months. But you can't stick to 6 months in a program. Now what happens in my OPD, the problem that I face, as I told you, we give the first line free of cost. The moment the child finishes 6 months, he's out of the program. When the program says, we don't give you any longer AKT. And if I feel that clinically he's not improved and I need to give a little more, then the child has to buy. Okay? But this is in a center where we can follow up these cases. We are talking about centers all over the country where we have shortage of staff, where we don't have this kind of follow-up. These kids are going to finish 6 months therapy and be off it, including your tuberculosis meningitis, your bone TBs, where you are expected to treat for 1 year, they'll finish therapy in 6 months and be out of the program. So this is one issue that is there. So we need to talk about a lot of issues when we are talking. Now, India, we were the highest burden of TB in the world, if you consider total number of patients. But because we take percentages, we don't fit into that highest number one, because percentage-wise, it would be South Africa actually. But if you look at number-wise, then we are such a huge population that number-wise, we are number one in the world in the incidence of TB. So why did we fail in control of TB? Now, TB program actually started in the 1960s, immediately post-independence. It was known as TB Control Project, TCP. Okay? In India, what happens is we have a high burden of adult TB. Now, if somebody in the house has TB today, he is going to infect another 10. Those 10 may not develop the disease, but they'll definitely have the bacillus in their system. So he's going to cause 10 more people to get latent TB. So we have a wide pool of adult TB who are sputum positive. And we have a wide pool. We have almost 2 million people who have latent TB, so they don't know that they are harboring the bacillus, but they have this latent TB. And this latent TB is sometime or the other going to get reactivated and cause active TB. So if we really want to control TB, we need to not only take cure of the positive patients, but also control the latent infection. Where the TB program fails majorly is we are only talking about cure. We are only talking about cure of a identified patient. We are not talking about eradication of this latent TB at all. So if you really want to remove TB from the system, we need to take care of this latent pool. The government recognized this very early. So they said if we want to take care of latent TB, the best way to do is to give protection by a vaccine. And that's what your BCG vaccine came into the picture. The hypothesis was it will give you primary protection, so you won't get infected by the bacillus, and it will also give you secondary protection, so by chance you still get infected, your latent infection will not progress to disease. This was the hypothesis behind your BCG vaccine. We've been taught in our books, BCG prevents severe forms of TB. It prevents your miliary TB, disseminated TB, CNS TB. Have you ever gone back and asked all your CNS TB or miliary TB, did you receive BCG at birth? You would have asked in your history. And how many of your patients said not received BCG? None. Most of them would have received BCG at birth. So it didn't prevent the severe form of TB. So this hypothesis that the government came across, that to prevent latent TB we need to give BCG vaccine. Subsequently in 1979 there was this BCG trial that was done in Chennai, and it found that this vaccine does not give you primary protection nor secondary protection. So this vaccine actually miserably failed for what it was introduced for. Okay? Because we still don't have a vaccine for TB which is very effective, we continue to give this vaccine. But the moment we'll have a more effective vaccine, this vaccine will be out. We don't need to give. The other thing is we give BCG at birth. Probably the protection of BCG will be for the next 5 years. Okay? You may not get this BCG protection lifelong. So some countries who are high prevalent actually give a second BCG in the adolescent age. We don't have any data of how effective it is at that time. So protection of BCG is going to be probably only for the first 5 years. And why we need that protection in the first 5 years? Because we know if we get latent TB in the first 5 years of age, progression to disease is highly likely. And that's the reason we give INH prophylaxis in children less than 5 years of age. We don't give this INH prophylaxis for everybody who's MANTU positive. Today, if I did MANTU in all of y'all, probably 60% of y'all will be MANTU positive. That means 60% of y'all are harboring latent TB. And to take care of that, I need to give you INH prophylaxis. Okay, it's not possible in a country like ours. But yes, people in the US do this. If you are going to immigrate to US today, I'm talking about immigration. I'm not talking about going for studies or short-term or long-term stay. I'm talking about immigration. If you go to the US today for immigration, they'll do a MANTU test in you. And if you're positive, they'll label you as latent TB. And they'll advise you to start 6 months of INH. If you are negative, they'll repeat your MANTU after 3 months again. And if you convert it, they'll still label you as latent TB and treat you. Okay, because they don't want that latent pool in their society at all. It's not possible for a country like ours. The next thing that the government decided is we need to take care of all patients who are having TB. So we need to treat them. Medicines are expensive, so if we give them free of cost, these medicines will work. Okay, so they started giving free treatment of TB to everybody. See, it's very difficult to implement this in India in all districts. So initially, this policy came only on paper. The policy has come on paper from the center, but what happens at ground level is different. Similarly, it came on paper, looked very well, but to implement that, free treatment means you needed staff to give the medicines, you needed a good supply of medicines constantly, you needed to have a medicine which was not substandard, and you needed to ensure that these patients would come for treatment and take the treatment. So what happened was, initially, when this TB control project was there was no quality check on the type of medicines that we were recruiting in the government or how the program was functioning. It was only on paper. Most of the patients would still prefer treatment in private sector. Okay, they used to think doctors in private sector are much better. That's the mindset. Doctors in private sector are much better, so they would take it from treatment. Then in treatment schedules, everybody used to follow their own treatment regimen. Whatever, 3 mahina lo, 4 mahina lo, take this combination, take that combination. So doses were arbitrary, schedules were arbitrary, treatment regimens were arbitrary. So this is the problem that occurred with treatment. And that's the problem that 1980s we started seeing drug resistance coming up. Initially streptomycin, then the subsequent other drugs that came up. Then we had an epidemic of HIV. And we all know HIV and TB go hand in hand. HIV suppresses your immunity and you're going to have a resurgence of TB. So that's the time when the TB epidemic gained ground. And plus I told you about this free TB treatment and erratic schedules. We got MDR TB that started evolving. Then the government realized something in 1990s, no, we have to do something about this. It was actually the WHO which put the pressure, and the TB program, the project, was changed to RNTCP. So it became as Revised National Tuberculosis Control Program. What was the main highlight of RNTCP? It was the same as your TB control program. What was the main highlight of RNTCP was it going to be observed therapy. Okay, so the patients would be given medicines, they have to take the medicine in front of the doctor or the staff and go home. So they decided to keep it as daily observed therapy or DOTS. So DOTS was a major component in 1993. This was the time WHO actually declared TB as a global emergency. By the time DOTS was actually covering entire India, it took 13 years. Okay, so for 13 years, we had a shortage of these drugs and directly observed therapy. Again, the problem with this program was you only give the treatment. Then what happened to the patient, we don't know. Like what I told you, what happened in my clinic, in the OPD. 6 months are over, patient goes off the program. Whether the patient is healed, patient is relapsed, patient is alright, no. 6 months over, patient goes off surveillance. So that's the problem that occurred with DOTS. So where DOTS failed is it took care of treatment. It didn't take care of control. Again, only DOTS. Only identify the patient, put him on treatment. What happens to the society? We are not aware. Ideally, what should DOTS include? That the government first should provide the human resource and infrastructure. Then there has to be passive case finding. Right now what is it is? It is passive case finding, but then it has to be active case finding. Right now we only do with a sputum examination, okay, with a microscopy. Now we've got gene expert being introduced all over the country, but currently we still have gene expert only in 4 centers. So we don't have this facility everywhere. Then they decided that treatment has to be short therapy. There must be a regular supply of medicines and there must be a system in place for tracking and monitoring these cases throughout the country. So what went wrong with DOTS is, it's not going to interrupt the spread of tuberculosis, it's only going to take care of an individual patient. But by that time, this patient has infected 10 other individuals. So you didn't break the cycle. And DOTS can never control TB you need to control latent TB. If you want TB to get eradicated, you need to control latent TB. Now the treatment of TB, even if we just take this component of dots, that's the treatment of TB. If we look at treatment, treatment will bring down mortality, but it does not prevent transmission. Today, if you get a patient who's sputum positive, how long is he going to be infectious while you put him on therapy? He'll be infectious for another 3 weeks. Do we have that infrastructure to quarantine the patient? No. By the time you've detected, he may have infected so many others. So we have got no way of quarantining a patient. Okay, we tell them they all stay in one room. Most of them, socioeconomic status is lower strata. They all are staying in one room. We tell them isolate the patient. Not possible to isolate because they all are staying together. You tell them wear a mask. They are not compliant with that because they don't want to wear a mask. If you are sitting in your clinic and you have to see a TB patient, which is the ideal mask that you are supposed to wear? You are supposed to wear an N95 mask, ideally, which we can't afford. So what we use is a surgical mask. The surgical mask is also a good enough filter. How many of you all have seen your colleagues having TB? Colleagues, doctors. All of you all have seen that occurring. What precaution could we have taken to prevent transmission to us? One is TB is airborne. Okay, so these bacilli will remain suspended in the air. So whenever you see a patient of TB, you need to have a good ventilation in a room. What I mean by good ventilation is you may be sitting in an AC room. Now this AC room should have changes of air circulation. So the new air should completely change the old air at least 12 times in an hour. So it should have 12 air cycles per hour. What are your ACs doing? They're giving you 6 cycles per hour. Okay, so we are not getting enough new air. So we are breathing in that old air. What I do in my clinic, not at Wadia. Wadia I don't have an AC. But in my private clinic, what I do, when I see a TB patient, I keep the AC on and open the windows. So that way I get cool air, but at the same time the air change takes place. Okay, so that is what you have to make sure that you have at least 12 air cycle changes in an hour. What I do at Wadia, in the clinic I have only 2 windows. So I make all the patients sit out in the garden. At a time only 1 patient comes inside. So the amount of bacillus in the air is going to be less. All of us wear a mask. Once the OPD gets over, leave the room. Don't sit there and eat lunch. Don't sit there and eat food because it's there in the atmosphere. It will remain suspended for 2 to 3 hours. Okay, so these precautions if you take, then you prevent transmission to yourself. So when you have a TB patient, try and isolate the patient. If you can't isolate, cohort these patients together in one particular area. I'm talking about indoor patients. And for yourself, wear a mask and make sure you get these air cycle changes. Why India is facing TB epidemic? I think India's major problem for anything is population. Okay, for corruption it's population. For disease it's population. For lifestyle it's population. For traffic it's population. For potholes, name it, everything, it's population. So if we can get control of population, we'll control a lot of things here. So when we talk about treatment of TB, chemotherapy will prevent, it will cure the patient, but it won't prevent the transmission. And obviously we need shorter regimens. We can't have this. Do you take antibiotics for 7 days when you get cough, cold or you've started? No, you don't take. You yourself will be harboring an ESBL. Okay, but you will not finish. How do you expect this patient to finish 6 months? In children, I tell you, compliance is good. Why? Because children don't have to take medicine by themselves. They are force-fed. Mummy comes, yeah, it goes inside. Right? So children, compliance is not a problem. Drug-resistant TB, I'm telling you, is only because of our schedules, the treatment duration, non-compliance, and wrong doses that we are giving. Now, if you look at treatment failures from individual point of view, we looked at it from a program point of view. But if we look at it from individual point of view, as doctors, we are failing because we don't use proper guidelines. We are not compliant. Even if we take the guideline, we say, no, I know better. I will treat it this way. And sometimes there is absence of guidelines. For example, in cases of latent TB with drug resistant. You have an MDR sitting at home and the child is MAN2 positive. There are no guidelines what to do. Okay, so you also sit quietly and say, I don't know what to do. Let's wait and watch. So this is what happens. Second, drugs. Drugs are poor quality, substandard, irregular supply in the government sector, sometimes wrong delivery. Now you know drug doses have changed. INH we used to give at 5 milligram per kg initially. Now we are giving INH at 10 milligram per kg. So drug doses have changed. Drugs are unsuitable due to drug resistance. Patients, lack of information, lack of money for treatment. They think there are a lot of side effects because of the drugs that they are taking, so they don't take the medicines. They may have malabsorption, vomiting because of the drugs. And then there are social barriers. I'll tell you one incident that I found, after which I don't think all of you all will ever eat food from the roadside. I once went to a place and I just was passing by. I saw that fellow selling, what was he selling? Vada pav or something like that he was selling. And on his stall, there was this TB medication. Okay, and he was constantly spitting away and all that. So I asked him, are you on TB treatment? No, I'm not on treatment. Next thing is denial, and he throws away the medicine. It's fecal-oral route also. Okay, Mycobacterium bovis, intestinal TB. Why do you get isolated intestinal TB? So social barriers. Because patients look at it from stigma, a lot of patients don't want to take the medicine. Then the government decided that no, TB enough, we made a mess, now let's get it reportable disease. So you have to report each and every patient who has TB to the government. What the government does after reporting, we don't know. Okay, so TB in 2012 became a reportable disease. Now we have to learn something from industrialized countries. TB was an epidemic worldwide in the 18th century. How did these countries actually control the TB? If you can look at Britain and Singapore, what they did is they banned spitting in public places. Completely, no spitting allowed. If India could do that, can you imagine the amount of diseases that we could control? Just ban on spitting. Okay? TB, if you look at it in India, it is a class disease. You will rarely find TB in upper class or middle class. You will find TB rampant in the lower socioeconomic status. Because maybe when the upper class and middle class are more educated, secondly, they have an infrastructure to have a bigger house, and probably the cleanliness factor and the hygiene factor, which is not available to the lower socioeconomic status. So if we need to really control TB, we need to go into a lot of civic issues and infrastructure issues. So what we need to do, this is what I feel that what we need to do. We need to have not passive surveillance, but we need to have active surveillance of TB. Today, if somebody is diagnosed TB, the entire family should be screened for latent TB. What we do is chest X-ray, if the child is found to have TB. We don't do an adult. Adult medicine, nobody actually does family screening. So that active surveillance should be there. We should be age specific in our surveillance, okay? Especially children should not be missed out because they are the sources of latent TB. Health education is important, cough etiquette and not spitting in public places. Private sector in India treats 80% of diseases in the private sector, so you need to involve the private sector. It has to be a public-private partnership. We have to actively search for latent TB and treat the ones, especially children less than 5 years, for latent TB with 6 months of INH. There has to come an effective TB vaccine, which is going on. So probably we'll get a TB vaccine very soon. And we need to have a better regimen rather than the 6 months therapy that we are giving. Now WHO has come out with a strategy. Till now we were on dots. Now WHO has come out with a strategy known as End TB strategy. What is the strategy? They want to decrease the TB death by 95%, cut new number of cases of TB by 90% between 2015 and 2035. So it's a 20-year program. No family should be burdened with the expense of treating TB, so TB treatment should be free of cost. And this program should be evaluated every 5 years at 2020, 25, 30 and see how the success of the program is. But the main program is that TB death should be less than 95% and no new TB less than 90%. Cut down the cases by 90%.